Hi guys, so you might be wondering why is there a whole nother video attached to this mess that you've already been sitting through? Well, the truth of the matter is when I was making the presentation, I recorded more strip interpretations than I needed. So rather than let that go to waste, I've created this practice strips video instead. So these aren't necessary in order to complete basic arrhythmia or advanced arrhythmia, but it does give you the opportunity to maybe look a little bit deeper or find some additional guidance on strips that maybe give you trouble. So Flutter is a good one. You know, how to count the P waves and the conduction ratios with that. Or third degrees. I know I've got a little bit of extra there and some pacemakers. So just feel free, go through this section on your own if you want to. If there's things there that you find helpful, outstanding. If it's something you don't feel you need, not going to make you do it either. Thanks again for watching. So here's another opportunity to go through and practice this again. So we have our solid mark right here, and right over there. And so I've got 1, got 7 beats. Is it regular? Nope, sure doesn't look it because we have that narrowing between 5 and 6. So we're going to say irregular. And we have an ectopic early. But we don't see any pattern right offhand. And since it's irregular, we'll just take 7 times 10, and that gives us 70. Okay, so, and actually the ectopic early, we'll just go ahead and number it, is number 6. So let's go through our P waves. We'll do the normal stuff first for all 3 of these. And so our normals. Looks like all of our P waves that we can see are upright and uniform. And we'll come back to that ectopic beat. We'll ignore it for now. Are they regular? Well, let's measure out. So from the start of this one to the start of this one is right at about 24. And the start of this one falls right at about 24 as well. So we've got that and that going for us. So that seems regular. And I have 1 P for every QRS. Now what's the PRI for my normal beats? Well, let's see here. I've got, let's measure this one out here. 1, 2, 3, 4. And last but not least, our QRSs, they are uniform. And they have a QS pattern. And what is my QRS width? So it's about right here to here. 1, 2, 3. So that's actually normal as well. And this whole bit here is normal. And that's normal. And this is normal as well. So it looks like we actually have sinus rhythm in this case. So now we just need to look at our ectopic and see what's going on there. And so our single ectopic beat, beat number 6, has a upright P wave, and it actually matches the other P waves as well. So we're going to be upright and uniform. I have 1 P for the 1 QRS, and so that's good there. from a PRI standpoint, let's go ahead and measure him, and we will have right here to right here, 1, 2, 3.5. Which is also normal. A little bit shorter, but it's essentially the same. So that's good there. And then last but not least, my extra beat is uniform. In fact, it matches because it has the QS pattern. And then when I measure this out, just about 2.5 or so. And there you are, which is also normal. So all in all, that is just sinus rhythm with a normal sinus rhythm with an early normal beat, and so we call that with PAC. So we'll approach this like we always do. You've got your marks right over here, and so you've got 1, 2, 3, 7 beats, so 7 times 10 equals about 70. But looking at this, things seem pretty darn regular. Doesn't look like we have any ectopics, but we do have a pattern of 4 P waves for every QRS. And I will come back and explain that in just a second, but let's go ahead and get a specific measurement. So from R to R, this distance right here is going to be 22. Actually, that one's closer to 1, 2, 3, 23. Which is still pretty reasonable. But that is our ventricular rate. The atrial rate, let's see if this is Brady. Sorry, this is normal. My atrial rate is going to be a little bit more tricky. In fact, we're just going to measure from the tip of one P wave to the next. Well, where's the P wave? This whole thing looks like a mess. Well, let's go all the way out here between 6 and 7. You have what looks like a T wave coming down, and this bottom point here is essentially where your isoelectric line should be, and this next one is way over here, and so that winds up being about 5.5 boxes across. So if we take 1500 divided by 5.5, you will get the magic number of 273 beats per minute for your atrial rate. So that atrial rate is indeed between 250 and 300, and that's just one of the beats that we measured. There's a lot more to choose from. Either way, atrial is extremely fast, but ventricular is reasonably normal. We have a nice regular rhythm, no ectopies. However, I noticed a pattern to the P waves. And so your question is, how the heck did you get there? So for a flutter, I'm going to say that there are 4 P's for every QRS in this case. And so how do you prove that? Well, let's just start with this one here that looks like it's part of the T wave. In reality, it's a P wave combined with a T wave, and I'll show you how. So we'll just label, we'll come over here between 3 and 4, and I'll label this one A, B, C. And so if you look at the way this is going, D is hiding right here. In fact, the QRS canceled it out. So what we're looking at is the P and T, are combined. as well as the QRS concealing the number D, and so, or letter D. And that's how you get to that. And so you can repeat it again if you want to, where we say this is A, this is B, this is C. And so in that open space, if you just imagine it there, is D. And that helps support that idea that that irritable focus is just firing repeatedly over and over and over again at a rate of 275 beats per minute. And then every once in a while, the QRS pops through. So we're going to go ahead and say that that's that sawtooth pattern. And we're going to say 4P per QRS. And it is regular. PRI, can't measure it because we don't have a PRI to measure. As for the QRSs, they are definitely uniform. And they have an RS pattern. And if we go ahead and measure their width, measure from here to about here. That's 1, 2, 3, 3-ish, right around there. Which is also normal. So in this case, we have atrial flutter with a 4-to-1 block. Okay, so I've got that there, and we're going to go ahead and count these out. 1, 2. $160 for the rates. However, looking at this, it is super regular. There's no ectopics and no real pattern. In fact, it's the T goes right into the P wave if you were just kind of looking at it. But we'll come back to the P waves and we'll look at those closer. In fact, let's just go ahead and get a strong R to R reading. And this one will be the easiest because that's on a nice solid line. And that is 5, 10. So okay, so let's take a look at these P waves. If we do what we traditionally do and we look at that R wave, QRS, and look right in front of it, it looks like a mess. It looks like an inverted P wave. I don't know what to call that. It's kind of crazy. Well, just take a second to deconstruct it a little bit. So you have an upright QRS that points this way. What follows a QRS? Well, it should be a T wave. And so if this is a T wave pointing upright, and then there's this downslope, and then something comes up again, that thing that's coming up surely should be the P wave, correct? Well, that P wave is so close to the QRS, in fact, it just kind of cycles through. And that's that hallmark, that sawtooth, that no matter how fast the rhythm's going, you can still imagine that traveling underneath everything. And so in this case, we're actually going to say that it is, that's A, that's B, that's A, that's B. This is a 2-to-1 block. Or we can say 2 P's per QRS if you're used to think of it that way. It's very regular. What's our atrial rate since we've gone to the trouble of figuring this out? Well, from here to here is right about 5. So it's atrial. We'll say that this was vent up here. That atrial equals 300 beats per minute. Okay, so we've got the P waves basically figured out. Can't do a PRI. My QRSs are definitely uniform. They have basically an R, possibly a tiny S conformation, and they are tiny. They are snug. They are just barely over a box. So we're going to go ahead and say it's 1.5 times, sorry about that, 1.5 times 0.04 equals 0.06, which is normal. So we're tachycardic. We're in a 2-to-1 block, and so that gives us atrial flutter with 2-to-1 block. And that actually makes sense now that you've looked at a few of these. Atrial rate of 300. If every other beat goes through, that's 300 divided by 2, which is basically 150. Kind of makes a little bit of sense. All right, so for a bit of a challenge, we'll look at this like usual. We've got that and that, and just staring at it from the back, it's irregular for sure. There is a bit of a pattern though. It looks like 2 together, space, 2 together, space. So we'll ask if there's a pattern. There's no ectopics. And so let's go ahead and count up a rate. So we'll do 1, 2, 3, 4. So we'll do 9 times 10 equals 90. Pretty straightforward, and that's normal. And that's about all we can do for that ventricular rate. So let's take a look at those P waves. And there are a lot more P waves than there are QRSs. And in fact, they're kind of sharp, aren't they? And that really gives us that sawtooth appearance. So how do we figure this out? Well, we're going to go about this the same way we have for all of them. We'll start here between number 4. So the number 4 QRS comes up into a T wave. So we'll label that A, and this one B, and this one C. And so if we follow that undulation, we'll see that there is a D here, and then we have A, B, and A, B, C, D, A, B, A, etc., etc. So we actually have a 2-to-1 and a 4-to-1 block going on in this case, and it's repeating back and forth. So there is a pattern, but it is variable. Again, no PRIs. Now that we've discovered that these are indeed P waves, let's go ahead and get a P to P, or an atrial rate, and that's again at about 5 boxes. So QRS, they are definitely uniform and have a solid actually no, we'll just say it's a QS pattern, and the width on those, it's a little bit challenging to mark out, but we'll say it's there and there, which is right about 2 boxes. Which again is normal. Actually, I want to do a little bit better job marking these. So the QRS starts at this sharp point here, and it ends basically right here. So it'll be 1, 2, 3. Actually, I take that back. which again, it's still normal. And so what are we going to call this? We're going to call this atrial flutter with variable block. And in parentheses, if you want to be really fancy, you can say it's a 2-to-1, 4-to-1. And there you are. So this is typically what we see with AFib. This is an actual patient and what you would see. We can see immediately that it is irregular and that it's slow. And of course this is a 6-second strip. There's really no pattern. And there's no ectopics. So my rate, 1, 2, 3, 4, and 5. 5 times 10 equals 50. And so we're bradycardic. So we know we're slow. We don't have any P waves, but we do have these just little undulations going throughout here. And so that is what your F waves look like. No P waves, so no PRI. And our QRS, well, we are uniform. We have a QRS pattern, and we're going to measure that at about 2.5. So we'll go 0.04 gives us 0.08. Sorry, 0.10, which again is perfectly normal. And that, you know, because of the bradycardia and the F waves and the irregularity, that is atrial fibrillation with slow ventricular response. So we've got a 6-second strip. Looking at it, it's almost regular right up until the end, and then we have this break through here. So we're going to say that we're irregular. And we'll count them out. There's no pattern that we can see, and there's no ectopy. In fact, when we look closer, there's really no P waves. You know, you could maybe try and imagine some of these could sort of be P waves, but the fact that they're consistently not present is your real big tip-off that this is probably going to be AFib. Now, as for our QRS, those are uniform. Looks like we have a QRS pattern. And if we're to measure these out, one, 2-ish. So 2 times 0.04, which is normal. And because our rate is normal, and we have the F waves, and our QRSs are altogether normal, throw in a dash of irregularity, and so you have atrial fibrillation, specifically controlled. Controlled AFib. All right, looks pretty ugly, doesn't it? I will just go ahead and open up with this and say, check the patient. Now, actually, in reality, this is a patient I was taking care of. I was actually standing at the bedside when this rhythm occurred, so I knew what was going on, but if I wasn't at the bedside, sure as heck this would get my attention, and I'd go scurrying in there to try and figure out what's going on. And I'll talk more about this history, this patient's history, but first, let's go ahead and pick this one apart, shall we? So we'll switch colors to green here, and we'll number them off. Now, this is a 6-second strip. And while you're looking at this, you can tell that it's pretty regular. There's no ectopic beats. They all pretty much look the same. They look pretty ugly, actually. All right. So rated 200, very tacky. And no ectopy. Now, the undulates, I bet you're wondering why I said that, but if you'll notice that this entire thing kind of goes up and down like this, that is the patient's respiratory pattern. They were tachypnic, which is why you had basically a breath every 3 seconds. They were not having a good day. But ultimately, that's what explains that undulation up and down. Since it is regular, let's go ahead and try and figure out the rate. And so we'll measure between 7 and 8 because that one is on a nice solid line. And number 8 is right about here. And that is 7. And so if we do, that gives us 214. And if you measure that a little bit wider, because there's 1 or 2 of these that are like that, if you divide that by 8, you get 187. Either way, that's a nice fast strip. Now, can you see any P waves in this? Well, first, let's look at this a little closer and see if we can't pick apart what we're looking at. And so we'll start here on the end with the 16, 17, 18. Right up here, this is your R wave. This is your S wave. This right here is your, that right there, sorry, is your J point. And this is your T wave and P wave combined. And you have R, S, it's your J, and then this is your T and P, R, S, TP. Okay, that hopefully gives you an idea of what we're looking at across here. And now that we know that no matter where we look, I'm just going to put marks above them, you really never see a good P wave anywhere. Someone could make the argument about maybe some inverted P waves after the QRS, and I think that's a perfectly reasonable discussion to have. And when the heart rate's this fast, without a 12-lead EKG, a true one to tell, you just can't. Either way, super fast. So we've got that, and that. Those are all there. For now, I'm going to say there's no discernible P waves. And so for that reason, we have no PRI, which then brings us to our QRS, and how the heck we're going to measure that. So I pointed out the J points earlier because that's what we're going to use to mark these out. So I'm going to start right here in the middle. Beat number 9 is a pretty good one. And so beat number 9, the QRS starts about right here. And then your J point ends about right here, just barely on the other side. 1, 2, 3. And so if we look over here again, any of these other ones here. Number 7 is a pretty good one because that starts on a solid dot, and this J point again ends right about here. 3. So we have uniform. They have an RS pattern, and we have 3 times 0.04 equals 0.12, which is actually normal. So for that reason, we have very fast, we have regular, no P waves, and we have normal QRS. SVT is going to be the best answer that we can give in this scenario, simply because we don't have more information. This strip here is also second degree type 1. However, it's got a few unique features that I think are worth exploring, so that's why we're going to go ahead and go through it. First things first, this is longer than 6 seconds. You can see here and here, so that's my 6-second mark at this spot, but it goes on a little further. And the reason why I left it this way was so that you could actually see the entire pattern unfold in front of you. But we'll go ahead and do like we always do, and we'll say that this is beat number 1, 2, 3, 4, and 5. So in reality, in that first 6 seconds, we have a heart rate of, sorry, I'll actually take this back 1 second. We have a ventricular rate of 3 times 10 equals 30. So this patient has a heart rate of 30-ish. Regardless, it's not good, even if you look at what you have in front of you. We will talk about what that atrial rate is, though, because we do have more P waves than QRSs, and we'll say that we are irregular, question mark pattern. There's no ectopy, but we do have more P's than QRS's. Well, how do we prove that? Well, let's go ahead and mark our P waves first. And I will say that this is a P wave, that one, that one. All right. And since we have those identified, let's go ahead and figure out a rate for those, or how regular they are. $22. And we'll just do dashes across here. This one, that is 22. And this one here is another 22. All right, so we do know that we have an atrial rate of 1,500 divided by 22. 68 beats per minute. So we have a normal atrial rate, but because of the dropped QRSs, we actually are running at a bradycardic rate. So ultimately, we're going to stick with this one and say that we're bradycardic. And dig a little bit further. So the P waves, we are upright and uniform. I have more more P's than QRS's. And so my dropped beats are here. I've got a dropped beat here after beat number 1. And the item that we now realize is that we're missing a P wave. If you actually look at it closely, and you can see that if we measure over by 22, it's 5, 10, 15, 21, 2. There should be a P wave right here. And it's hiding within the QR, or hiding within the T wave. And because of that, we will actually mark down that we have a dropped beat here as well. So we actually have 1, 2, 3 blocked P waves. And that we are regular. Now, let's go ahead and measure the PRI as best we can. We'll start with this first one. And we'll say that it is from here to about right there. And that comes out to 10. Now we have our drop. And then our next one is from here to about right here. And that is 10 again. But now, because we didn't drop a beat, we can actually measure from here to here, and that gives us 13. Then we have a drop, and then we'll measure again. It comes out to 10. And fortunately, we can measure again, and gives us 13. So we did establish a pattern of a larger and larger. So and 13 times 0.04 equals 0.52. And going, gone. So we did meet that criteria of a repeating pattern of there's a PRI, then it gets longer, and then you drop a beat. PRI gets longer, drop a beat. Granted, the very first part of this is a little confusing because it was long, then just dropped. And that can happen sometimes with second degree type 1 is it can be variable. Sometimes that pattern's perfect, other times it might jump around a little ways. Just depends on the patient and where they're at with their treatment. But either way, that's enough right there to show that we've got second degree. Second degree type 1. We're still going to finish out and look at our QRS, and then we can say the few that we do have are uniform. We have RS configuration. The width on this is, we'll just measure beat number 3. 1, 2.5. And that's perfectly normal. And then we can say we have 3 dropped QRSs. So yeah, ultimately, there you are. Other notes I just want to make while we're on this, just to talk about the fact that this patient is really slow. They have a heart rate of 30. It's severe bradycardia, and because of that, they're likely to be symptomatic. So be ready to treat them for your symptomatic bradycardia type stuff. So do your ACLS. Yeah, and so there'll be drugs you can do and other interventions like temporary pacemaking. We'll talk about more of that as we go forward. But again, treat the patient, look at the patient. That's what matters. And that's honestly more important than the rhythm they're in. The rhythm helps you decide what type of treatment they need. All right, 6-second strip. We've got 1, 2, 3, 4. And from a ventricular standpoint, I've got 4 times 10 gives me 40. Regular, no pattern that I can really see. I've got more P's than QRS's. No ectopy. Let's go ahead and look at what we got. There's 1, 2, 3, 4, 5, 6, 7, 8 P waves that I see. We'll go ahead and measure these out. Let's go ahead and do between these two. From here to right about there or so comes out to 16. And we'll measure across here. That's also right at 16. So we know that the P waves are pretty regular. But if I look at this, I'll notice that there's actually 2 gaps. I'm actually missing some of my P waves. I feel like there should be one in this zone and one over here. How do I prove it? Well, I can take either from here forward. If I count forward 16, that puts it right here. And if I want to double check, I'll take this one and go back 16 and see it actually matches. So I've got a P wave hiding here, and then if I do the same right here, I can see that that P wave is somewhere in this zone right around here. So I do have 2 additional, so that's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 P waves. But regardless, there's 16 in between. So we do 10 times 10 equals 100. And that gives me, let's see, just under 93 and change, 94 actually. Okay, so that's normal. However, my ventricular rates, we never did finish that one up. So if I just measure between these first 2, here and here, I get 34. Is 44. So you're normal and you're Brady. My P waves are upright, uniform. My P's outnumber my QRS's. They are regular. So I'm dealing with a block, but no particular pattern. Because in this first section between 1 and 2, I've got 3 P waves. But between 2 and 3, I've only got 2. Between 3 and 4, I've got 3, but one of them's covered by the T wave. It's a bit of a mess. In terms of PRI, what I can manage to measure, if we look at this first one, it's 2, maybe? So I've got a 2, but if I don't trust that and I want to go further back, well, that's 16 plus 2, so I'm looking at maybe 18, which seems way inappropriate. If I look at my second one, I'm looking at something like 11, 12, 13, 14. And then my next one, I'm looking at 5, 6, 7, 8, 9, 10, 11 or so. So again, those are just wildly inconsistent. And to that end, they don't reset, the pattern's not there. And so that alone should let me know that this is not a first degree, this is not a second degree type 1 or type 2. Wildly inconsistent, no pattern, no reset. That clues me in right there that I'm probably dealing with the third degree. I'm going to go ahead and finish out everything though, noting that my QRSs are uniform. I'm dealing with RS for my pattern. My width, if I'm going to measure that, and this is a really good example of how to measure widths using the J point. If I look at the second beat, we can say that the QRS definitely starts right here. And it goes up and it comes all the way down and then it goes up again. And it's really hard to tell where the S wave ends and the T wave begins because it's all just kind of one slurring slope. The only consistent thing I can do is say that at the end of the S wave, where it's nice and sharp, that's the only place I'm certain. As far as I can tell, the rest of it's all T wave because I don't have a true ST segment. And so I'm going to actually mark right here on this line. And so that gives me a total of 3 small boxes. And if you do that for each of these, you'll find that it's 3 every time. Which is normal. It's on the a little bit wide, but it's essentially normal. And that's pretty much where we wind up with this. Oh, I guess there was one more QRS I did not measure, or one more PRI I didn't get done. That was this very first one over here on the left, across here, and that one's 6. So 6, 2, 14, 11, definitely crazy. I'm going to go ahead and not count that 18. Just shows you how far those things can be off and why that helps demonstrate this is truly third degree heart block. Just like that. One more time. We've got one. This is a 6-second strip. I can promise you that. I'm not going to talk as much during this one because you're just going to watch me fill this out the same way I've done dozens of times already. It is indeed very regular. I don't have any ectopy. I do have more P's than QRS's, so that's a good clue. If we measure out the ventricular rate from beat number 1 to beat number 2 all the way across here, that gives us about 44.5. So if I take 1500, that gives me 34. So let's take a look at those P waves. We'll keep using the red ink like we have. Already you just saw how I went P wave, wait a minute, there should be one there, P wave. So it looks like beat 1 may have one hiding. And look at how beat 3 is actually landing right on top of one, just like that another strip that we had done previously. Well, if I think there's one hiding under beat number 1, how do I find it? Well, I can just look, and if I take one quick second, I can see that in beat number 3, the very start of it, there's a P wave immediately followed with a QRS. In beat 2, that's a normal looking QRS, right? It just has the small q, big R, small s. And then if I look at beat number 1, I notice that I have my Q go, my little Q, my R goes up, comes down, and then I immediately have this little bump after it. And sure enough, that's my missing P wave. It's not a T wave, it's a P wave. Because if I look at beat number 2 and 3, those guys don't have T waves really to speak of. In fact, actually, this mess right here, that's the T wave. That's way out here, and in fact, this P wave is landing on that T wave. So this is actually the T wave way out here. Anyhow, let's do some measurements and prove that our assumption is correct. So if I measure from start of U to start of U across here, that is right at 17. And if I measure back again, sure as heck, that comes out to 17 as well. And of course I can measure forward just to be certain. And a little bit shy, but yeah, 17 again. So my P waves are nice and regular throughout. That's good to know. While I'm busy measuring, we'll just go ahead and do our P wave analysis because I've been staring at them anyway. And we note that we are uniform, upright, regular, more P's than QRS, so I'm dealing with a block. Go back and do my atrial rhythm before I let that slip my mind. 1, 2, 3, 4, 5, 6, 7, 8, 9. But we're nice and regular, so 1500 divided by 17 gets us 88, which lines up just fine. In terms of the PRI measurements that we have, this very first one, I kid you not, is 15. My second one right here is 7. And this is 1.5, if that's correct. Or it could be due to this one way out here, but at that point that's 15, 16, 17-ish or so, which again is wildly inappropriate. So we have 7 and then we'll just go ahead and say it's 17. There's no pattern there. The repeat's not in place. You talk about how the QRSs and the T waves are overlapping or the QRSs and the P waves are overlapping one another. All of that just adds up to being wildly inconsistent, no pattern, and no reset. That's pretty much everything we need right there to go ahead and call this third degree. We're going to go ahead and look at our QRSs just to be thorough, and that those are uniform with a QRS pattern. And my total width on that, let's measure the second one here. Right at 3. Which is still normal and narrow. So, third degree AVB or complete heart block, whichever of those you choose to use. another round of VTAC, and if you see this on the screen, the answer is always going to be the same. Check the patient. Looking for a pulse. May need to do ACLS. Alright, so I pre-marked out the rates on here just because it was a little bit longer one. And we've got 21 times 10 gives us a rate of 210, so we're definitely fast. We are very irregular. There's no pattern. And it's all ectopic. Now it does undulate a little bit, that it seems to get kind of big, small for a second, bigger, small for a second, bigger. So it does have a little bit of a size change to it. In terms of P waves, there's just really not much of anything to say about that. I don't have anything in the way of PRI either. And so now we come over to the QRS. On the QRS itself, they're all different. There's a few that look similar, but I could never, it would be very difficult to pick one of these and then drag it across the screen and go, yeah, this is exactly the same as that one. I've got the change in amplitude. I've got the change in direction. You know, I don't really have a change in direction. It's just more of a, some of these get a little bit more blunted at the top rather than nice and sharp like their counterparts are. So I really can't quite say that, but I definitely have an amplitude and a overall style change with each one. If I measure them out and try and figure out exactly how wide they are, I'm actually going to use, you know, it's so difficult to find any of them that are appropriate for the width. What I can do is this though, I can say at the very least from here to here, let's see, that's 8 small boxes. And that very well could be the entirety of the QRS. However, I've got this little space here, which is fine, but then I've got another one that's 6 across. If I try and measure, if we argue and say that right here's maybe the start point, I measure from here, it goes down, it comes up, I've got a bit of a J point here, that's 8. Really difficult to sell that one as well. And thankfully about something like this, even if I can't get a great measurement on the QRS, the pattern itself really sells it, that this is just wild and crazy. In fact, I could measure right here and say from here to about, probably right here is my J point. And even then that only comes up to 2, which I don't think is accurate either. I do know that it is wide. I do know that it is bizarre. And that is really enough for me to say this is definitely some kind of VTAC. Of course, I'm going to go check the patient, check for a pulse, maybe do my ACLS, all those different things I need to do. But because it looks so weird and varied and inconsistent, we're going to call this one polymorphic, because that's the best answer for this type of scenario. And again, I bring you back to what ACLS and those types of things recommend, which is do compressions, shock them out of it as quickly as you can, defibrillation. And that is pretty much him in a nutshell. The story I do want to tell with this one, though, just while I have a moment, this was a Comfort Cares patient. We actually withdrew life support, the ventilator and pressors, and the patient rapidly declined. The family actually gave us permission to do the withdrawal of cares, and he stopped breathing, or she, I can't remember which. No oxygen was added to the blood supply now that they'd been extubated. And what happened was they had a global ischemia throughout his entire body, and in fact his heart, the entirety of his heart, was deprived of oxygen. This is one of the rhythms that his heart wound up producing over the course of all that stuff. In fact, it was very, very close to the end where that patient passed away, that the heart rate sped up like this and then rapidly declined shortly thereafter. So I want you guys to keep in mind that this is the rhythm that you will see when someone's heart's trying to quit on you, and why rapid intervention is so, so important. This particular patient arrived to the ER with CPR in progress. So just to give you an idea that this patient presented with VTAC for all that we can tell. And we'll go through this just like we normally would, because we still have to try and prove it as best we can. And we have longer than 6 seconds, but we've got 13 times 10 equals 130, so not crazy fast. We're definitely irregular. Not terribly, but enough that I think it would be a little bit too challenging to try and pin down exactly how fast the rhythm's going. I do have changes in size, and I've got these beats here. I'm actually going to put a little star right around them that are just off. They're not quite the same as the others, so we kind of want to come back to that. But otherwise, there's really no pattern. I don't have any P waves that I can really tell. There might be something hiding in there. I'd be hard pressed to prove it. So no P waves. No PRI. So our QRSs. They are all essentially different. We have a couple that look very similar, but not enough. We have change in amplitude. And we even have almost change in direction to a certain extent. Not massively, so I don't really think it's worth counting. If we're going to try and measure how wide the QRSs are, it's going to be a heck of a trick, because you really can't even tell where they start and where they begin on this kind of a strip. But we've got these larger, kind of more strangely shaped ones. So let's like try beat number 11. Right here, that's 1, 2, 3. That's right at 12. So 3 times 0.04 equals 0.12. That's a little close to being wide. I have a real tough time with any of these other ones making heads or tails of them. But overall, I'm certain that they're wide. And if you're trying to figure out what I'm counting as the QRS and the T wave and things, with beat number 8, this mess here is pretty much the QRS. And then this part here is going to be your T wave. The reason why you're seeing these little undulations, that's likely due to CPR artifact, as people are doing compressions and pushing on them. Pushing on the patient, touching them, do all those sorts of things. So it's wide. My T waves are, that I, as best I can tell, are inverse. And, you know, actually I won't call them, I'll say this. This part here where they're kind of fibrillating up and down, those are not F waves. Some people might be like, oh, maybe it's just a VTAC or a atrial fibrillation, or maybe atrial flutter, and that's what's causing all those. I really don't think it is. I think it's just artifact. Other things that we can make mention of, we can look at the sizes on them, just to see if there's any hints there. And you'll see that with the V lead and with the 2 lead, we definitely have plenty of beats that are well outside the margins on the the scale. So that's another great hint that we're probably dealing with a VTach of some kind. And ultimately what I'm probably just going to fall down and call this one is it's another great case of polymorphic VTach. Now, calling it polymorphic VTach, is that going to change anything? No, it's not, because we're still, CPR is in progress, because you know what you do, you check the patient. And you look for a pulse, start compressions. Start compressions if there's no pulse. And that's what really needs to get done in these cases. Here's a strip that helps demonstrate the challenges that real life can present us with sometimes when we're trying to read strips. This is a 6-second strip, and as you can tell, there's not a lot going on. It's pretty sparse. The most important things I want to draw your attention to right away is going to be these little hash marks and the letter P. Most modern, at least for our facility, but when we use Philips monitors, for most facilities, the bedside monitor is able to recognize certain events and then mark them accordingly. And so for this one, they actually put little hash marks there when it senses that there's a pacer spike. So that in situations like, let's go ahead and get these beats numbered. So if you look at beat number 4, or even beat number 3 for that matter, it is very, very difficult to see the pacer spike on these. Beat number 5, it's pretty easy because it's kind of tall, and even in beat number 1, if you look, they're actually kind of tiny, but they're there. But for beat number 4, they're just barely perceptible. On a monitor, they should show up as a different color to help give them contrast so that they stand out a bit better, but when you print them out in black and white like this, those little hash marks are what give you an indication of where you need to be looking on the waveform strip itself to see if the pacemaker was doing what it was supposed to do. All that being said, let's go ahead and approach this like we usually do. 6 times 10 equals 60. We are regular. We've got 1 spike per P wave and 1 spike per QRS. So we got 2 spikes per beat. We don't have any ectopy, but I do have a question about artifact. I do really feel like I have some. I think through here, this is a lot of artifact, which makes it really difficult. And even a lot of this kind of fuzz between 4, 5, and 5 and 6, I feel that's all artifact as well. So let's, if we're nice and regular looking, what kind of rate do I have? And we'll measure between 4 and 5, and I will say about right here. And again, I'm measuring from when the QRS actually begins, not from when the pacemaker fired. So that's 5, 10, 15, 20, 1.5, 2, 3, 4.5, so 25. Equals 60. So there we are. We have a nice normal rate. That's what we want to see. From the P wave standpoint, we don't have any. If you look through here, there's always an atrial pacing followed by a ventricular pacing. So from that regard, if you look at, we'll work backwards. We'll start with beat number 6. You can see right here where we've got a P wave. Number 5, a bit of 1. Number 6, 6 has 1, 5 has 1, 4 has a little bit. 3 this might be, but that's a bit of a question considering all of the artifact. Beat number 2, it's difficult to tell, but I think that could be some. And then beat number 1, it's actually fairly easy to see. They're not uniform. And some of that may be due to the artifact that we're dealing with, and that's causing them to come across as being odd. Or the fact that, the patient is being atrial paced. In real life, they often look like this, that you have a very difficult time seeing the P wave occur with atrial pacing. But ultimately, what we do know is that everything looks very, very consistent, and there is some kind of depolarization occurring. So that's enough to tell us that we do have capture, and that's what we want to see. So since we have our spikes, let's go ahead and try and figure out what the PRI might be. We'll use beat number 6 here because it's pretty clear. One, 2, 3, 4. Now this is a bit tricky if you really want to think about it, because the patient is getting AV paced. So that means the pacemaker is in charge of both the atria and the ventricle, which means that it kind of took the AV node completely out of the equation, and that we really can't even measure if the AV node's functioning at all. What it does tell us is kind of the setting that the pacemaker is put at, and if it's functioning correctly, because if you have AV paced but it winds up being this huge first degree block, well, you got to question, is it even functioning properly? But at 0.16 seconds, that's perfectly normal. Last but not least, the QRS. Native, well, we sure as heck don't have any, do we? The pacing portion, those are almost uniform. Beat number 1 does look different. But again, you've got the pacer spike right before it, and the rest of them are all uniform. And they have what looks to be an R prime S pattern to them. They are wide and tall. How wide are they exactly? Well, let's go ahead and measure. In fact, number 5 will be a pretty good one to measure with. 3.5. .14, and so that's just enough to say they're wide. And we have 1 spike per QRS, and that's enough to say that the patient is atrioventricular paced with 100% capture, or you could say that they're 100% AV paced, or AV paced with 100% capture. Any of those would kind of work. For those that are curious, there'll be more on this in the advanced arrhythmia lecture, but you might be wanting to know why beat number 1 looks different. This is what a fusion beat looks like. I'd mentioned it in terms of the malfunctions and things that can go awry. It's just a timing issue. Where the pacemaker fires at not quite the right time. Doesn't really change what we're looking at here because the patient is still 100% AV paced. demand pacing. This is a 6-second strip. You can already tell that it's quite irregular. You've got some paced beats, some that are not. Overall, we've got a rate of 8 times 10, so that gives us 80. Some pacing. No ectopy. And I'll talk about beat number 7 and why that's not an ectopic beat. And we've got 1 spike per QRS. And you may not think that's true because of beat number 7, but again, I'll explain that in just a bit. The P waves. Do we really have any native P waves that we can make out? Nothing very clean. Right here in beat number 1, that looks like a P wave, but we don't have much for beat number 2, kind of for beat number 3, not really for, beat number 5, not really. 6 doesn't have much, so I'm going to go ahead and say that we don't have anything consistent, and that we're not going to be able to get much out of that. Odds are it's probably F waves that we're looking at. Just some fibrillation that's managing to come out as looking occasionally like a bit of a P wave. We don't have any paced ones either. And so that leaves us with no PRI. As for the QRS, native, we've got beats number 1, 2, 4, 5, and 6. And with those, they are uniform. They have an RS pattern to them. They're pretty narrow. Let's go ahead and use beat number 1. Oh, sorry. I wrote that incorrectly. Let's try that again. 0.08. So that's perfectly normal. Our paced beats have a bit of a different story. And so the paced beats are number 3, 7, and 8. And you're going to ask, well, I don't see a pacer spike on number 7, so that can't be a paced beat. I agree with your logic. However, I ask you the question of, what does beat number 7 look like? It looks identical to beat 8 and 3. And what can happen is occasionally the pacer spike doesn't have enough electricity or is not captured by the external monitor, the telemetry, in a way that makes it show up. And so it's probably so tiny it just matches right here within the rhythm strip itself, and you can't even see it. That's why most modern telemetry machines, when they print things out, they actually put little hash marks up above, and we'll put the letter P next to it to let you know that that was a paced beat. Whereas this one here, they would put an N for normal. And you've probably seen that on some of the strips we've gone through already. That's what that's indicating, normal versus paced. And so on ones where you can see the spike, it's like, well, duh, I figured that out myself. But for strips like this one, where maybe on beat number 7 you don't see the mark, but it looks like a duck, it walks like a duck, it quacks like a duck, it's probably a V paced beat. So, just to kind of wrap this up, it's wide, it's tall, there's a spike for every QRS. And we have wide, and we're tall. If we measured it out, and I can use number 3 because that one's pretty clean looking. right at about 3, so it's a little bit narrow. And that's not too bad. But again, given how drastically different it looks and the fact there's pacer spikes associated, that's enough for sure to say that that's V-paced. So if we put the whole picture together, we can say that this is likely AFib with demand V pacing. The other question you want to ask is, well, when does it kick in? What is the rate setting on this? How slow does a patient's heart have to get in order to trigger? To answer that question, I'm going to draw some stuff out, and so it's going to be a little bit of a mess, but just hold on with me here for a second. We'll do the start of the QRS. And so I've measured these out already, so I'm just going to go ahead and write them in to save a little bit of time rather than counting everything out. And this one is 23. And these aren't quite perfect, but they're enough that you can get the idea of what's going on here. So if we throw these numbers up to give you an idea of how fast the patient's heart rate's going versus how fast the pacemaker is going. If you take 1500 divided by 15, that gives you a rate of 100. Now if you divide by 17, your rate drops down to 88. If you divide by 22, 68, and you divide by 23, you get 65. And so what did that tell us? Well, it tells us that as long as a patient, if you look at these here, between 2 and 3 and 6 and 7, that if the patient's heart rate drops below, looks like 65 is probably the magic number, then the pacemaker will kick in and maintain a rate of around 65 to 68, somewhere in there. Whereas if it's going faster than that, like with these here, 3, 4, 5, etc., 4, 5, 6, that rate is well above the 65 cutoff, and at that point the pacemaker does not have to kick in. So that's that rate responsive, the demand pacing. It only does its job when it's needed to keep the patient's heart rate up to where it needs to be. Begin by numbering our slide. So, in terms of actual QRSs, we have 0. Gives us a heart rate of 0. So we are basically in asystole. There's no beat whatsoever. In terms of the pacer, that is from about here to here. That one's 20. Okay, so we have regular pacing. No QRS or response at all, honestly, to spike. And of course no ectopy and no pattern. So in terms of P waves, there's nothing. In terms of PRIs, there's nothing. And in terms of QRS, there is nothing. We just have pacer spikes, but no depolarization. And that really does just make this straight up, total loss of capture, or complete loss of capture, however you want to phrase it. What kind of response are we going to have to seeing a strip like this on the screen? Well, you are going to do BLS and ACLS. Assuming the patient's a full code. This could have been someone that we withdrew cares on and we're anticipating them passing away, in which case that pacemaker may fire a couple times and then stop altogether because it realizes the patient has no heartbeat anymore. But either way, so if this is unexpected, be ready to do BLS, ACLS. Compressions are going to be your big move. And probably temp pacing is what's going to be needed. So look at those as being your two big things that most likely are going to be necessary. Just to remind you what the causes of loss of capture like this could be. It could be severe oversensing. It could be lead fracture, lead displacement, this is something that you could see in a temporary pacemaker patient where the wire is floating inside of the heart and it moves away from the ventricle far enough that it doesn't cause depolarization, but you can still see the spike. And your millivolt setting is too low. Setting on pacer too low. So if you're dialing it in, like say with ACLS and doing the pads, so again, this is temp. For temp pacers, you have to dial up the energy high enough so that it can create capture. If the output, the amount of electricity that the pacer is sending, isn't enough to depolarize the patient, you may see something like this where there's a spike but no actual reaction by the patient. Yeah, so that is the worst case scenario of loss of capture. So here's a real life example of pacemaking from my collection. And we'll just go ahead and mark this like usual. So we have a heart rate of 40. But our pacer is set to that one comes out to right at about 22. Gives us 68. So we've got a pacemaker that's set for 68, but we only have 4 beats on the screen, or 40, for my heart rate that's on the screen. That right there is a huge hint that maybe we have a pacemaker firing when it shouldn't be. Regularity-wise, we're going to have to call it irregular because we have that flattened portion at the beginning. We don't have any ectopy. Have any pattern. We just know that no capture on the first 2 pacer spikes. And so this right here and this right here are the pacer spikes that didn't catch. And so we have no capture. How do I know that those pacer spikes, A, that they are pacer spikes. Well, if you look at the subsequent beats, you can tell that sharp depolarization right there matches exactly where the pacer marks are on the remaining beats with the strip. What I'm missing is, of course, the big QRS following it afterwards, and so that's basically how you recognize that you've got a loss of capture scenario. Not to mention, a pacemaker should fire pretty regularly, so to have that distance go without a pacemaker being there to the rescue is another great sign. P waves, native. I'm going to say we either have, I'm hesitant to call it F waves because it's just so jumbly throughout, so you could question if that's the case. But I definitely have artifact for sure. And in either case, it doesn't change much of what's going on. We just don't have any true native P waves. From a paced standpoint, we got nothing. So without that, I cannot measure a PRI. So we move to QRS, native, and we have none. There's no native QRSs, because obviously there's this huge stretch here where it could have tried and it did not. So none. From a paced standpoint, we have, so I'll just call this 1P, 2P. 1P, 2P, spike, no QRS. And then remaining beats, so 1 through 4. And we have 1 spike per QRS. They're wide, kind of tall, not really. So those are the signs that we're looking at V pacing for that. Ultimately, then, what am I going to say? I'm going to say that this is V paced with loss of capture is the best way to phrase this. Or ventricular paced with loss of capture, because that's exactly what I see. Remind you what the causes of things like this can be. We can have lead fracture. We can have lead displacement. And actually, in this case, that's exactly what happened. There was a temporary pacemaker in place. The wire and patient movement caused it to float away from the right ventricle and led to this occasional capture that was going on. So this is, again, pointing out why it's so imperative that when you have temporary pacemaker patients, especially with the wire, that they hold still as much as possible, rarely any movement. In some cases, you don't even turn them. And you have to be really, really creative with how you provide cares to these patients until they can get a permanent pacemaker placed or whatever the case may be.